Hello, it's Dmitry again. Today I'll be looking at another section of the Mehlman Medical Internal Medicine PDF. Today we'll be looking at the dermatology section. This section is just a hair under 30 pages, and so this will probably be divided into 2 or 3 videos, this being the first of that number of videos, either 2 or 3. So let's begin. I am derm. High-yield derm conditions for internal medicine. Tinea capitis. Cause is dermatophytes, that is to say Microsporum trichophyton. Classically circular, scaly area of scaly alopecia. Treatment should be oral griseofulvin for patients only. Patient plus classmates is the wrong answer on NBME. Another NBME question asks you how to prevent. The answer should be avoidance of sharing of hats. Use of medicated shampoo is the wrong answer. Seborrheic dermatitis. Inflammatory response to overcolonization with Malassezia yeast. Presents as an itchy scalp with flakes. If severe, presents as a weeping papules / scaling of the hairline. More common in adults. Don't confuse with tinea capitis above, which is a circular area of scaling alopecia, more common in children. Treatment would be topical selenium or ketoconazole shampoo. Cause can sometimes occur in HIV patients, sudden onset in high-risk group. The answer should be do an HIV test. Interesting. Tinea corporis, aka ringworm, which you can see right there. Ringworm. Question will often mention a dog at home. Treatment would be topical miconazole or clotrimazole. Treatment for tinea pedis, athlete's foot, is topical terbinafine or topical azole. So that's your tinea corporis right there. Well, that looks pretty bad. We call that a lymphangitis. Above image shows a sporotrichosis, sporotrix, Schenki, or Schenkii, but similar pattern can also be seen for miscellaneous burns or puncture wounds of the hands that cause ascending infection towards the axilla. Students early in their preparation know that the sporothrix is classically a papule on the finger caused by rose thorns. This presentation is usually too easy for real USMLE though. Treatment for sporotrichosis is oral itraconazole. USMLE can show you an image similar to the above one where they list answers like phlebitis, arteritis, lymphangitis, etc. Answer just lymphangitis. Cellulitis. Staph aureus exceeds strep pyogenes, group A strep, as causal organism, must give beta-lactamase resistant beta-lactam in the methicillin class, that is to say decloxacillin or flucloxacillin, or first-generation cephalosporin, that is to say cephalexin or cefazolin, or augmentin amoxicillin clavulinate. Now, the amoxicillin and penicillin alone are wrong answers. It's the combination that's relevant. 90% of community staff, that is to say MSSA, produces the beta-lactamase, so amoxicillin and penicillin alone will not work if staph is the cause. Erypselis, infection of upper dermis and superficial lymphatics, caused by strep pyogenes, group A strep, which eclipses the Staph aureus for Erypselis. Looks worse than cellulitis, but is more superficial / not as bad, has characteristic fiery red appearance, and may appear well demarcated with raised edges. Although group A strep is greater than staph for Erypselis, the treatment is the same as cellulitis, oral decloxacillin, cephalexin, or augmentin. Because staph can still cause it, penicillin alone can be used for strep pharyngitis. So let me read that again. So treatment is the same as cellulitis, that is to say oral decloxacillin, cephalexin, or augmentin, because staph can still cause it. Penicillin alone can be used for strep pharyngitis, though. Acne. Well, that looks like some pretty bad acne right there. Acne caused by Propionibacterium acne is not difficult, but I've seen enough students select tinea faciei fungal infection of face for simple acne. First-line treatment for acne on USMLE is topical retinoids, that is to say, topical tretinoin, not oral isotretinoin. Latter is only for severe acne. Topical retinoids like vitamin A inhibit sebum production. They cause photosensitivity and desquamation, peeling. Topical benzoyl peroxide is second line for acne, although often co-administered with topical tretinoin. It clears pores and kills bacteria. A topical clindamycin can be used if topical retinoids and benzoyl peroxide are insufficient. If topical antibiotics is insufficient, oral tetracycline is used. The latter can causes blistering photosensitivity. Last resort is oral isotretinoin. Must do a beta-HCG pregnancy test before commencement due to the teratogenicity. Yeah, I mean, that's something you have to be aware of, teratogenicity. Oral isotretinoin does not cause problems with sperm in men. Topical retinoids in both men and women do not cause teratogenicity. Okay, so they're going to say that topical retinoids do not cause teratogenicity. However, the actual oral isotretinoin will be teratogenic, and that's a risk factor you take when you take that. So just make sure that you're not pregnant if you're taking it. Is this acne continued? I believe this is acne continued. Some more acne. Above image shows the high yield photosensitivity to, well, this is not acne, sorry, but this is part of the same section. So it says here, above image shows the high yield photosensitivity due to the topical retinoids. Answer should be avoidance of sun exposure. Tetracycline photosensitivity, in contrast, tends to be blistering. Do not choose answers such as avoidance of spicy/sweet foods for acne questions. Yeah, so basically both tetracycline and retinoids, topical retinoids, induce photosensitivity, and so be aware of that. Tinea faciei, fungal infection of the face. Treatment would be topical azoles, clotrimazole, meconazole. Meningococcus. Neisseria meningitidis, gram-negative diplococcus. Causes meningitis plus characteristic non-blanching rash. Low BP can be endotoxic shock, but students should bear in mind Waterhouse-Friderichsen syndrome is often asked, given hydrocortisone to increase the BP after normal saline is administered. What about herpetic whitlow? So herpetic whitlow, one of the highest yield spot diagnoses on USMLE, HSV1/2 infection of the finger, in children can be acquired via touching mother's cold sore, that is to say, during breastfeeding. In adults, classically in dental workers, treatment would be, because you're putting your hands near their face, right? Treatment would be topical oral acyclovir. Lyme disease. See that? Look at that target right there. So Lyme disease, Borrelia burgdorferi, a spirochete, spiral corkscrew shaped, causes Lyme disease spread by Ixodes ticks, same as Ehrlichia or Babesia and Anaplasma. Primary Lyme causes a classic target rash known as erythema chronica migrans, but a high yield point is that the rash need not be a target on USMLE. It can merely be circular with no clearing, but the target is classic. Bell's palsy can also be seen in primary Lyme, where the USMLE will give two side-by-side images, one, circular rash on limb that is not a target, two, Bell's palsy, where the student needs to infer this is Lyme disease even though the rash is not a target, since Bell's palsy is high yield for Lyme. Second, Lyme tends to cause arthritis. Some sources say Bell's palsy is part of the secondary Lyme, occurs at least 1 month after initial infection, but I've seen USMLE give it as part of initial/primary infection. Tertiary Lyme can cause CNS and or heart problems. Treatment is doxycycline for most cases of Lyme. Ceftriaxone is given for advanced Lyme involving the CNS or heart. For children less than the age of 8 and pregnant women, give amoxicillin in place of doxycycline. There is an NBME question of a pregnant woman with a non-disseminated Lyme where the ceftriaxone is correct over doxycycline, and amoxicillin isn't listed. In other words, if the USMLE doesn't want doxy as the answer, they will not play trivia as to whether it's ceftriaxone or amoxicillin to be used as an alternative. But you could be aware that, in theory, ceftriaxone is harder hitting and preferred in cases as more severe. But again, they probably won't force you to choose between the two if you're not going to get doxycycline as your answer. we're making pretty good progress given the amount of time we've had on it. But that's in part because there's so many pictures, of course. So let us continue. Scabies. You can see a picture right there. Scabies. Sarcoptes scabii. Lesions classically described as linear burrows can become superinfected with Staph aureus. That doesn't sound fun. Treatment would be topical permethrin. Disseminated scabies can occur in HIV patients. Treatment is oral ivermectin. Topical permethrin is also treatment for pediculosis or lice. Bed bugs. Well, to be fair, none of these things are fun, to be fair. So bed bugs caused by an insect called a Cimex, Cimex, grows as clusters of itchy lesions on the limbs or torso. Cutaneous anthrax, caused by Bacillus anthracis, classically causes a black eschar, seen in postal workers and farmers. Pulmonary anthrax leads to hemorrhagic mediastinitis. Treatment would be ciprofloxacin. What about tularemia? Right there, tularemia. Caused by Francisella tularensis. Okay. Cutaneous tularemia can present as ulcerative lesion. Can also cause bilateral atypical pneumonia. Rabbits are a classic source. How do you treat it? Doxycycline. Hot tub folliculitis. Rash caused by Pseudomonas from water sources. Increased risk in diabetics. So hot tub folliculitis, okay. Measles, okay. What am I even looking at here? I don't even know what I'm looking at right now. AKA rubeola. So measles, aka rubeola, causes a head-to-toe maculopapular rash. Image shows Koplik spots, pathognomonic whitish lesions on buccal mucosa. Immigrant history on USMLE symptoms implies unvaccinated status. That's true. Can rarely cause a subacute sclerosing panencephalitis, reactivation of latent infection in CNS in teenagers. Measles continued. Rubella also causes a head-to-toe maculopapular rash, but rather than Koplik spots, suboccipital and post-auricular lymphadenopathy, tenderness on back of head and behind ears is characteristic. In a similar vein, we're going to be talking about mumps now. Mumps, these are all, I believe they're called, I forgot the name of it. There's a family of viruses that this is referring to. It's, let me look it up right now. I used to know this stuff like the back of my hand, you know? But what do we call them? No, I know that. Paramyxoviruses. They're both paramyxoviruses. Measles and mumps are both paramyxoviruses. Mumps causes POM, parotitis, orchitis, and meningitis. Doesn't typically cause a rash, though. Remember, orchitis, parotitis, meningitis. So think about what's going on in different places. Parvovirus B19. Fifth disease, slap cheek disease, facial erythema caused by parvovirus B19 in peds. Next best step would be to check serum IgM titers. If IgM titers are not listed, choose bone marrow biopsy. Can cause pure RBC aplasia, that is to say only RBCs are low, or full-blown aplastic anemia where all cell lines, RBCs, white blood cells, and platelets are down. There is increased risk of pure RBC aplasia and aplastic anemia in sickle cell. Once a child has developed the red cheeks, he or she has immunologically cleared the illness, that is to say, if they turn it into a behavioral science question, tell the patients to chill out and relax because the child has cleared the virus. Can cause body rash plus or minus arthritis in adults, same as with fifth disease. Next best step is checking the serum IgM titers. Roseola, I think, okay. Roseola caused by HHV6, described as a spiking fever followed by a rash. That is to say, child will have a high fever for 2 to 3 days, followed by a rash. Eczema herpeticum, HSV1/2 infection superimposed on eczema, often self-inoculated from touching cold sore when crackled skin of eczema. Herpes infection can present with fever, lymphadenopathy, and tingling, burning, and painful rash, herpetic neuralgia. Treatment would be acyclovir. Dermatitis herpetiformis. So you can see the picture right there. Extraintestinal cutaneous eruption that occurs in patients with celiac disease. Despite the name, it is not actually herpes. It is IgA deposition of dermal papillae. Do not confuse with eczema herpeticum. And it is what time right now? It's 16 minutes and some seconds, so I'm going to take a brief break and come back to you. Okay, I am back. Let us continue. Hidradenitis suppurativa. Skin condition characterized by painful abscesses in sinus tracts, most commonly in the groin, axilla, and under the breasts. Frequently affects apocrine glands. Cause is a combination of genetic and environmental factors, idiopathic. Sorry. That came out of the blue. Idiopathic. NBME is a surgical excision of lesions. And so that's hidradenitis suppurativa. That's the presentation. Looks unappealing, you could say. Pediatric shingles, right there. You need to know that pediatric shingles is a thing. Classically seen in immunocompromised children, that is to say, due to chemotherapy. Shingles is aka herpes zoster and is caused by varicella zoster virus, VZV. Herpes zoster is not a virus name. Herpes zoster literally is just another name for shingles, which is caused by VZV, human herpes virus 3, HHV3, not HSV1 or 2, but HHV1/2. Yeah, so HSV1 and HSV2 are HSV1 and 2, but this is HHV3, which is varicella zoster virus. Herpes zoster oticus, VZV, shingles causing perioral lesions, can concurrently affect CN7, CN 7 leading to Bell's palsy, Ramsay-Hunt syndrome too. Kaposi sarcoma. So Kaposi sarcoma right here, caused by HHV8. Kaposi sarcoma associated herpes virus is in immunocompromised patients, i.e. AIDS or chemotherapy. Classically, it's with AIDS. Kaposi sarcoma are violaceous, tumorous lesions of vascular lymphatic origin. Question can show you an image much such as above, and then the answer is just anti-neoplastic for the treatment, whereas answers like antifungal or antibacterial, etc. are just wrong. Anti-neoplastic. You say, how could it be a neoplasm? It's because, well, I mean, this is what it is. I mean, it is a neoplasm. Even though it's induced by a virus, it is a neoplasm in and of itself. It's very weird. I mean, it's called Kaposi sarcoma. I'm not 100% on the mechanism of how it develops, to be fair, just to tell you up front, but it is, at the end of the day, a neoplastic condition. Even if it has an origin in having HHV8 virus, in all fairness. So, it's a virus-induced neoplasm. Pityriasis rosea, caused by HHV6 or HHV7, self-limiting, starts as a herald patch, larger pink ellipse above, usually on the back or trunk, then spread upward onto the shoulder blades. Christmas tree distribution. USMLE will show you the image and expect you that you can make a spot diagnosis. Can occur in teenagers, although more common in the 20s. Tinea versicolor, right here, caused by Malassezia furfur. Fungus causes spotty hypopigmentation. Patient usually lives in a subtropical areas like Florida. Can occur in teenagers who surf/go to the beach. Treatment would be topical and selenium. For tinea versicolor, topical selenium. Molluscum contagiosum, very high yield spot diagnosis for peds, caused by pox virus, classically skin colored or reddish. Papules with central umbilication. USMLE likes to give vignette where the kid went to a recent pool party. Mycobacterium marinum, unusual diagnosis but asked. Vignette will say a kid recently went to the aquarium or water park, now has red lesions and on the arm and hand. Can occur in adults as well who work at aquariums or water parks. Leishmaniasis, this is not fun. Leishmania donovani, protozoan, unicellular eukaryote, spread by sandfly bite. Can cause skin cancer. USMLE likes Middle East is endemic. I've seen Iraq on NBME. Visceral disease known as a Kala-Azar, which causes an elevation in LFTs and pancytopenia. MAI, or Mycobacterium avium intracellulare, can cause lymphadenitis with classic reddish violaceous lesions on the neck or pre-auricularly. Secondary syphilis. Treponema pallidum spirochete image shows the macular-papular/nodular body rash. Palms and soles are classically affected in a secondary syphilis, but question need not mention it. Diagnosed with serology, VDRL/RPR ordered with FTA, before FTA, but latter more specific. VDRL can be falsely positive in patients with antiphospholipid syndrome, usually lupus, SLE lupus, patients with lupus anticoagulant. USMLE questioning can also show you a picture of condylomata lata, wart-like lesions on the genitals, plus tell you there's palm/soles rash. Then the answer should be treponema pallidum. Treatment would be penicillin. Arsenic poisoning. Mees lines or white lesions seen on the fingernails in arsenic toxicity. Arsenic is present in small amounts in fertilizers, which causes plants to flourish. Gardeners at increased risk. Arsenic can also cause palm/sole rash, arsenic keratosis. Eczema, type 1, immediate, can occur as part of atopy, that is to say asthma in winter, hay fever, rhinoconjunctivitis in spring, eczema in summer. Remember that 1/3 of asthma patients have cough variant asthma, that is to say only have dry cough, usually worse in the winter or with exercise. Treat with oil-based emollient and topical corticosteroids if steroids used greater than 5 to 7 days continuously. Thinning of the dermis may occur. Yeah, you can use corticosteroids, and they say apparently treat with oil-based emollient and topical corticosteroids. Yeah, and that can help with the condition. And it's saying type 1. I would assume they're talking about hypersensitivity because it's immediate. Okay. Just be aware of the different kinds of hypersensitivity reactions because I'm not 100% keyed in on that stuff, but be aware there's like a type 1, a type 2, type 3, type 4. We talked a little bit about that. We're talking about the immunology chapter. Actually, we talked about it with, I think, a reasonable amount of detail. So you can check that out or just look it up online. Urticaria, here we go right here. Urticaria, aka hives, type 1 hypersensitivity, again, can be precipitated by various allergens, including pollen, pet dander, and drugs. Erythema multiforme, immune complex mediated rash, type 3 hypersensitivity with many etiologies, HSV1/2 infection and classic cause. That's a type 3, erythema multiforme. Erythema nodosum, paniculitis, inflammation of subcutaneous fat that resembles a rash, seen with autoimmune diseases like sarcoidosis and Crohn's disease, as well as part of the serum sickness due to the medications like sulfa. Dermatomyositis. So here's a picture, there's several pictures. The image shows the heliotrope rash left and Shaw rash right, seen in dermatomyositis. Anti-Jo1 antibodies and electromyography plus nerve conduction studies equals diagnostic. Do not confuse heliotrope rash of dermatomyositis with malar rash of lupus. Give steroids for flares. Patient can also get Gautron papules above image and mechanic's hand, i.e. rough-surfaced scaly hands. Vitiligo, this is the Michael Jackson disease. T-cell mediated destruction of melanocytes. Relevance of internal medicine is that it can be associated with other autoimmune polyglandular syndromes as well as IgA deficiency. For example, B12 deficiency plus vitiligo equals possible pernicious anemia, or weight gain and fatigue plus vitiligo means possible Hashimoto's, etc. So you can have more than one thing at the same time. That makes it kind of complicated figuring out what's going on. Lentigo, age spot, elevated melanocyte number plus no change in melanin production, common on zygoma due to sunlight, not malignant. Latex allergy, Question will give you a nurse or laboratory technician. The implication is that he or she has been using gloves, resulting in contact dermatitis due to latex. Can also occur due to adhesives from bandages applied. And I want to go back a little bit. Did they talk about that before? They don't say it specifically. I don't think they say it specifically. So I want to look that up briefly. So contact dermatitis is what type of reaction? Contact dermatitis is what kind of hypersensitivity? Type 4. So allergic contact dermatitis is a type 4 hypersensitivity reaction. It is mediated by T cells rather than antibodies, meaning the skin inflammation develops 24 to 72 hours after exposure to the allergen. Okay, so that's going to be latex allergy, falls into that category. Rosacea. Idiopathic patchy facial erythema that worsens with spicy foods and alcohol. Slight pain of rash that may occur in cold weather. Occurs usually in middle age and older. Chilblains, aka perniosis, painful inflammation of distal capillaries due to the repeated exposure to cold air, followed by immersion in hot water from bath or shower. This is different from frost nip and frostbite. Frost nip is cold exposed skin, affects quickly, reversible, no skin damage. Frostbite is more severe and can result in damage such as blistering and necrosis. However, chilblains can be confused with tinea pedis since they can be extremely itchy. The patient might self-attempt topical antifungal spray foams to no avail. Treatment would be keep feet in warm water, avoid abrupt temperature changes. Aphthous ulcer, aka aphthous stomatitis, no treatment is necessary, not related to HSV1 or 2. Etiology is multifactorial, can be precipitated by allergens such as spice, T-cell mediated. Okay. Lichen planus, here's lichen planus, classically described as the peas, purple, peritic, polygonal papules. However, questions need not to mention that they're peritic. You just need to know that the hepatitis C plus red purple skin lesions means lichen planus. But hep C association. Aplasia cutis congenita. Again, aplasia cutis congenita. Absence of skin on the area of the scalp can be caused by teratogens such as methimazole, dumb seemingly pedantic detail. I know, but it shows up on Real Deal. Hereditary angioedema. Deficiency of C1 esterase inhibitor, not C1 esterase alone. Characterized by recurrent swelling of various bodily regions. Treatment would be danazol. Androgen receptor partial agonist causes liver to produce more C1 esterase inhibitor. NF1, neurofibromatosis type 1, autosomal dominant, one of the phacomatoses, neurocutaneous disorders, NF1/2, VHL, which is von Hippel-Lindau, TSC, which is tuberous sclerosis, something such. Let me look it up right now. TSC disorder. It is tuberous sclerosis complex. Okay. We were talking about that not that long ago in one of my other videos. So NF1/2, VHL, TSC, again, that's tuberous sclerosis complex, and then Sturge-Weber. Image shows a café au lait spot, NF1, café au lait spot, neurofibromas, axillary groin freckling, optic glioma, pheochromocytoma. Let's talk about tuberous sclerosis. Autosomal dominant, one of the phacomatoses. Image shows a adenoma sebaceum, angiofibromas, intracranial periventricular nodules, tubers, that is to say, hamartomas. Adenoma sebaceum, angiofibromas, cardiac rhabdomyoma, lymphangioliomyomatosis, subungual fibromas, renal angiomyolipoma. Well, that's a lot. That's a mouthful. So say that again. Intracranial periventricular nodules, tubers, i.e. hamartomas, adenoma sebaceum, angiofibromas, cardiac rhabdomyoma, lymphangioliomyomatosis, subungual fibromas, and renal angiomyolipoma. Image shows adenoma sebaceum. What about Sturge-Weber syndrome? classically a port wine stained birthmark, nevus lamaeus, but can be described as a violaceous papules in temporal distribution. Associated with leptomeningeal angioma, causing seizure and glaucoma. Condition is non-inherited and is due to somatic mosaicism. McCune-Albright syndrome. Triad of Coast of Maine cafe au lait, Coast of Maine presentation. Triad of Coast of Maine cafe au lait spots above image. Polyostotic fibrous dysplasia. Bone is replaced by fibrous tissue and endocrine hypersecretion, classically precocious puberty. Acanthosis nigricans. Brown/black velvety skin, usually along the nape of the neck, associated with hyperinsulinemia and type 2 diabetes almost always. Can also very rarely be seen in patients with underlying visceral malignancy. Basal cell carcinoma BCC. Classically pearlescent / slightly translucent. Telangiectasia is common. Borders can sometimes be described as heaped up or rolled. May or may not be ulcerated. Treatment for skin cancers on cosmetically sensitive areas such as the eyelid or nose can be managed with Mohs micrographic surgery on NBME. Actinic keratoses, aka solar keratoses, precursor to squamous cell carcinoma (SCC), classically described as red/scaly lesions on the forehead, ear, or arms of fishermen, farmers, or construction workers. Cryotherapy is usually the treatment. Squamous cell carcinoma (SCC), ulcerated lesion in the setting of a patient who's had actinic keratoses, that is to say, question says patient has a scaly red areas on the forehead for many years, plus now has recent ulceration. The answer should be SCC. Squamous cell carcinoma. Squamous cell carcinoma will not have telangiectasias or pearlescence/translucency as with the BCC, which is the, let's go back to it briefly, the basal cell carcinoma. It will not have the pearlescence, it will not have the translucency like you would have in the basal cell. What about keratocanthoma? Can be confused with squamous cell carcinoma, described as a dome shape with hyperkeratotic core surrounded by a wall of inflamed skin. Treatment would be surgical excision. And I don't know if I want to do melanoma or not. We just went over some other cancers, so it might be worth it. I don't know. Well, what I will say is this. It's almost 5 for me. I'm going to try to have some dinner, you could say. The video is only 41 minutes long, but we covered a lot of ground in terms of how many pages we've covered. I think we've covered about close to 20 pages. I don't think the chapter is that long because it's just so many images in the chapter. Let me see, 233. Yeah, neuro begins on 41. So we only have like a few pages left. Should I just go through the whole thing? Maybe I should just go through the whole thing. At that point, why not? Melanoma. So here's the melanoma. You can see it. Depth is most important for prognosis. Answer on NBME would be excisional biopsy, suspected malignant lesions in non-cosmetically sensitive areas, that is to say, not on red head/neck, can simply be excised with narrow margins. Excision of the additional tissue was important if the margins are positive, that is to say, the entire lesion was not excised. Full thickness biopsy answer on USMLE for suspected melanoma on back of neck. NBME question gives you a lesion similar to above on neck with full thickness biopsy as an answer. Excision of lesion is management for neck lesions if full thickness biopsy confirms melanoma. Do Mohs micrographic surgery for facial lesions. Punch biopsy is a type of full thickness biopsy. The question asks choose side of lesion for biopsy rather than middle of lesion. Students will be sometimes asked about shave biopsy. I have never seen this assessed on NBME, but the literature says that it can sometimes be used to remove superficial non-pigmented lesions. Whether a clinician does not suspect melanoma, performing shave biopsy of melanoma can create problems for assessing depth, prognoses, and therapy. So here's more melanoma right here. It says here acral lentiginous melanoma occurs on the palm/soles, areas not usually exposed to sun, more common in persons of African and Asian descent. which is another way of saying less common to people who are of European descent, I guess you could say, or of broadly speaking Caucasian descent. Can also occur under the fingernail. Now, is it drug stuff? I'm curious. It doesn't look like it. It looks like it's all just skin stuff all the way down. Seborrheic keratoses. Sun exposure and old age are the biggest risk factors, also seen in smokers, described as a greasy or waxy skin growths that appear like can be peeled off, not malignant. Sign of lesser Trele, sudden eruptive seborrheic keratoses secondary to underlying visceral malignancy, that is to say, unrelated to age or sun. Blue nevus, aka Mongolian spot, type of benign birthmark where the dermal melanocytes failed to migrate superficially to stratum basale, more common in Asians and blacks. Often mistaken for child abuse. Schedule routine follow-up. Wrong answer is contacting child protective services. Okay. Strawberry hemangioma, benign capillary, I guess you could say, benign capillary tumor that will grow slightly, then regress spontaneously within a few years. Oh, that's weird. No treatment necessary unless causing functional impairment. Don't confuse with cherry hemangioma, which is due to sun exposure in elderly and presents as a tiny cherry-colored papule. Okay, well that looks pretty weird, not gonna lie. They just say, don't do anything about it. Okay. If you say so. I would not like that on the side of my face. Right, see that right here? I'd be like, please get that off of me. Please get rid of that, please. And they're like, no, it's fine, don't worry about it. Cherry hemangioma. Benign capillary tumors caused by sunlight, benign greater prevalence as age increases. Students confused with strawberry hemangioma in peds. Preauricular pit. Preauricular pits are benign finding, usually not associated with any congenital disorder. No treatment is necessary. Can become infected, so do surgical closure if frequent infections are the case. Okay. Kasabach-Merritt syndrome, aka infantile hemangioma with thrombocytopenia, asked several times on 2CK assessments. Child will have thrombocytopenia due to platelet sequestration within the lesion, large and deforming. Do not confuse with strawberry hemangioma. The treatment is surgical. I want to take a brief break and I'll come back to you. We're on page 236. We'll wrap up on 240. We're in 46 minutes and now we're 47 minutes and some seconds. So I'll come back in some number of minutes. Skip ahead if you're watching a recording. Okay, I am back. Let's talk about Cushing syndrome. Cushing syndrome. USMLE wants you to know that purple striae are high-yield physical exam findings. Weakening of dermal collagen plus capillary walls means microbleeding into skin. Cigarette burn. Those are no fun. Question will show you an image similar to above, and then the answer will be contact child protection services. Can also be on the face / resemble impetigo if the different stages of healing. Keloids, disorganized growth of dermal collagen. Treatment is surgical excision, although recurrence is common, benign. It is also more common, I believe, in African American, or I don't know if it's Africans writ large, but it definitely in Black American population. I would assume it's in sub-Saharan Africans in general and people with much darker skin. I'm not sure. Let me look it up right now. Keloids are more common in who? Keloids are more common in African, Asian, and Hispanic descent. Individuals with darker skin tones are significantly more likely to develop these raised, overgrown scars, as keloids occur up to 15 to 20 times more frequently in these populations compared to people with lighter skin tones. So they're saying it's kind of like it's the actual skin tone that's related to it. Pseudofolliculitis barbae, aka razor bumps, increased prevalence in African descent. Curly beard hair grows back into the skin. Oh, okay. Treatment is to allow the beard to grow. USMLE will show you image and just ask the spot diagnosis. So pseudofolliculitis barbae. Okay. Milia, aka milk spots, clogged eccrine ducts, common benign findings in rabies. Sorry, in babies, big difference. Okay, milia, aka milk spots, clogged eccrine ducts, common benign finding in babies. No treatment is necessary for these. Exfoliative cleanser and topical low-dose corticosteroid would be wrong answers. The answer is no treatment is necessary. Varicose veins. Question will ask the next best step in diagnosis. The answer should be duplex venous ultrasonography for venous disease / valvular insufficiency. Treatment is compression stockings. Do not choose surgical interventions for varicose veins on USMLE. Superficial thrombophlebitis, similar to DVT, but in more superficial vein, presents as painful, warm, palpable cord at the ankle that may or may not track up to the knee. Treated with subcutaneous enoxaparin, heparin. Wrong answer is compression stockings. Very difficult question since the compression stockings are a common answer for venous disease. But if the patient has active venous occlusion, that is to say DVT or superficial thrombophlebitis, give heparin. In other words, for simple venous disease / varicose veins, choose compression stockings, but if the patient has an active clot presenting as a palpable vein with pain, give heparin instead. Buerger disease, aka thromboangiitis obliterans, condition is digital gangrene in males who are heavy smokers, contrast with gangrene due to diabetes, which is pedal. Treatment would be smoking cessation. Nasty stuff, isn't it? Anyway, Charcot joint, aka neurogenic joint. Here we go. Here's your joint for you. Charcot joint, aka neurogenic joint. Mechanism is a lack of appropriate joint sensation. That is to say, patient can feel his or her feet due to neuropathy, leading to damage, which leads to can't heal the area due to vasculopathy. Let me repeat that. AKA neurogenic joint. Mechanism is lack of appropriate joint sensation. That is to say, patient can feel his or her feet due to neuropathy, leading to damage which leads to cannot heal the area due to vasculopathy. Question will be diabetic with poor A1C, plus a foot ulcer, plus x-ray that shows disorganization of the tarsal / metatarsals. It's not pretty. Most of these diseases are not particularly pretty, in all fairness. Cryoglobulinemia, often present as levato reticularis, which is a mottled reticulated vascular pattern that has many etiologies associated with the hepatitis C. Cryoglobulinemia is associated with decreased serum complement protein C4, in contrast to C3, is sometimes down in the SLE lupus flares and group A strep infections. Yeah, that looks kind of crazy. SVC syndrome. So image shows Pemberton sign, facial erythema due to diminished venous return when arms are raised above the head, seen classically in Pancoast, that is to say, 8 apical tumors of the lung. So that's SVC syndrome. Can I get an acronym for that? Let's see, SVC syndrome. SVC syndrome is called superior vena cava syndrome. Okay. So superior vena cava syndrome right here. And think about something like an apical Pancoast tumor. Actinic purpura, aka senile or solar purpura, flat purple discolorations caused by damage to dermal collagen and blood vessels due to chronic sun exposure, commonly appear on the back of hands and forearms in elderly. Benign, may be mistaken for bruises. NBME question describes actinic purpura and then asks for mechanism. The answer is solar elastosis, which is a term that refers to degenerative changes to the dermis due to chronic sun exposure. Keratosis pilaris, benign bumps plus rough patches on the skin due to buildup of excess keratin. The excess keratin can block hair follicles and pores, causing small and hard bumps. No treatment is necessary. Emollients may be used. Not obscure condition I'm mentioning for fun shows up on NBME. So that's keratosis pilaris. And that is the end of the dermatology section. Even though it was just under 30 pages, because it's mostly pictures, or it has a large section of a large portion of it is pictures, there's a lot less text, and therefore it only took me about an hour, just under an hour. It's 58 minutes and some seconds so far to actually get the whole chapter completed. And for most chapters, that would take me about 3 hours and probably take me across 2 to 3 videos. So if you watched the video and got to the end, hopefully it was of utility to you in watching such a thing. Regardless, have a great rest of your day. Thank you, and